So, good morning, everyone. Okay, for today, we'll discuss the nervous system pathology. So, we have the functional areas of the brain, okay, in your basic anatomy. So, we have the frontal lobe, okay, and so we have them. First of all, just to guide ourselves, okay, we have this central sulci. The central sulcus will be the one, okay, that would delineate. Okay, it will delineate what would be the motor, okay, and the sensory cortex. So just anterior to the central sulcus would be the motor cortex, and uh, posterior to your central sulcus will be your sensory cortex. So all of the movement, okay, will be controlled, okay, of course, in the primary motor cortex, okay, your 3 to 1. Okay, then anterior to it, we have the frontal lobe that would be responsible for the judgment, for the foresight and voluntary movement. And of course, we have this little area. We have the Broca's area for our language. So, if in case the person have a stroke, either it would be a ischemic stroke or a hemorrhagic stroke in the Broca's area, okay, the patient would be aphasic. Okay, we have also the frontal lobe in here, okay, for the sense of smell. Your temporal lobe is very important for intellectual and emotional functioning. Okay, and okay, let's go now to the posterior domain. We have the sensory cortex. Of course, all the pain, the heat, and other sensation, okay, would be processed in here or be interpreted in here. The parietal lobe is for comprehension, okay, as of the language. So it's not only enough, okay, to hear the word or the uttered speech, but you have to interpret it, okay, based on what you have learned. Okay, example, I would be talking about the chair. So it is already processing in your brain what would be the feature of a chair. But of course, before you have to be able to interpret, okay, it must be processed here in the temporal lobe. Okay. Also, it's basically sensory in the posterior part. So your sense of hearing, your sense of sight, okay, in the occipital lobe, primary visual area. Okay, the vernix area is speech comprehension. So this patient, okay, if had a infarct, okay, or a lesion in the vernix area, he would be uttering the word that is incomprehensible. He can speak, but it can you can understand what she is talking about it. And of course, okay, the brain stem, okay, we have here it's controlled by your midbrain, pons, and the medulla oblongata, okay, for swallowing, breathing, and heartbeat. And of course, your cerebellum, that would be for coordination. So your finger to nose stairs, okay, your finger flapping, okay, walking in a closed eye. If you have a lesion in the cerebellum, all of those would be impaired. So this is a PET scan view, okay, that would reveal the different areas responsible, for instance, in hearing the words, okay. So in the temporal lobe for speaking in the Broca's area, for seeing words, okay. So it goes also into the occipital, okay, as well as in this area. Then for thinking about words, okay. So different mental activities will be taking place in different parts of the brain, and as revealed by this PET scan, it can measure this activity. So this is the Broca's area. Okay, it is composed of the cingulate and the parahippocampal gyri. Okay, so the hippocampus will be primarily responsible for short-term memories, which are later on converted into long-term memories. The thalamus would be for sensation, sensory, and limbic information, and send signal to the cerebral cortex for cognition. And also the limbic system is responsible for emotion, instinctive behavior. It includes also your hippocampus and part of the cortex. Now, there are lesions, of course, in the brain. So all of our organs are not excused or are not immune to have any pathology. So there are, first of all, we'll talk about your CNS degenerative disorders. So these are seen in patients who are aging. It basically affects functional groups of neurons. Sometimes the pathology can lie within the accumulation of the abnormal proteins. Okay, you can have a primary and secondary CNS degeneration. There can also be a global and local types. Now, the generic term for that would be a dementia, which is an acquired defect in the higher function. So this patient would have a functional, or rather, memory gaps. Even the language, insights, and planning are somewhat deranged, okay, from the normal human. More than 45% of adults, okay, over 85, okay, years old will be demented. Okay, so it starts, okay, usually at 30 years of age, and it rapidly progresses by the age of 70s. So what are the classifications of the CNS degenerations? So we have the neuronal degenerations. There can be a primary degeneration, which are as follows. We have the global primary degenerations, example of which will be Alzheimer's, the Lewy body, okay, and the frontotemporals. Okay, we can have also the selective or the systemic type. We have the Parkinson's and the Huntington's diseases. The secondary degeneration, okay, this includes your toxic metabolic, okay, lesions or pathology. You can have also infection in origin, nutritional. Okay, alcohol and B12 deficiency can also lead into the neuronal degeneration. For the myelin degeneration, okay, we have your MS, your multiple sclerosis, and your dysmyelinating disorder. These are your leukodystrophies. So of course, the more commons are, as I highlighted, would be your Alzheimer's, your Parkinson's, and your multiple sclerosis. So let's talk about first your Alzheimer's disease. Okay, this was coined, okay, by a German psychiatrist in 1991. Okay, August this is the first patient, 51-year-old patient with a personality, and he suffered from short-term memory loss. Now, a colleague, Franz Nissel, he proposed the silver stain, and he was able to demonstrate an amyloid plaques and neurofibrillary tangles. So, um, a case presented at Berlin in 1906, and it gained an international brain research organization recognition. So Alzheimer's disease, this is the commonest cause of dementia in the elderly. It can be sporadic, okay, which is the common type. It occurs if the patients are usually more than 60 years of age. There can be a familial predisposition. So kung lahi ng mga malilimutin, okay, so it can run into the genes. It can set in as earlier 10 years, okay, as opposed to the normal population. There can be an insidious onset of impaired higher intellectual function, altered mood and behavioral um, manifestation. It can also progress to disorientation, memory loss, and even aphasia. Okay? And of course, to a more debilitating disablement and immobilization. So the pathology lies within a significant cortical atrophy. There can be a secondary ventricular enlargement. So histopathologically, it would present with a neurofibrillary tangles or your tau proteins within the neurons. There can be also neuritic plaques or your alpha beta amyloid, which is located in the extracellular of the neurons. There can be also amyloid angiopathy around blood vessels. So the genetics would lie on a dominant genetic pattern, okay, quite rare for this genetically predisposed individual, 10%. The genes, okay, are located on 1, 14, 19, and 21 that can influence initiation and progression. Your chromosome 21 would generate the precursor protein for the amyloid protein or APP. Now, patients who have trisomy 21 produces early Alzheimer disease, okay? So you know that it's trisomy 21. This is a patient with Down syndrome. Chromosome 19 will also generate apolipoprotein. Some of them will increase the risk for the Alzheimer's disease by increasing the alpha beta amyloid deposition. So the pathogenesis would lie on the amyloid alpha beta, which is created when the transmembrane protein, sorry, uh, when the yes, the transmembrane protein amyloid precursor protein APP is cleaved by the enzymes beta amyloid converting enzyme and your gamma secretase instead of the alpha. Now, the deposition of the neurotoxic alpha beta around the blood vessels. So we call this your amyloid angiopathy, and also among the interstitium, creating the neuritic plaques. And it seems that it's disorganized fashion, so therefore it would creating tangles around the blood vessels, and this alpha beta amyloid plaque will lead into the hyper phosphorylation of the neuronal microtubule binding protein tau in the neuron to form a neurofibrillary tangles within the neurons. So both of these will be a neurotoxic leading into an atrophy of the neurons and a reactive glial proliferation, or what we know as your gliosis. So this is a schematic representation of the Alzheimer's disease morphology. As you can see on your left, this is the normal brain. The sulci are not increased. The um, um, the cortex are not atrophic. As you can see here on your left, the sulci are widened. The gyri are atrophic, as you can see in here, and it depends on the area. Would hit the most? Like example, if it would hit this Broca's area, then therefore the patients would be aphakic. Or if it's in the memory, then um, the recollection of those memories will be quite impaired. So, or sometimes in unfortunate cases, there would be a global atrophy, and therefore the patient would be significantly be debilitated. So this is the microscopic view of the normal brain, and this is the microscopic view of the patients with an Alzheimer's disease. So as you can see, these are the amyloid plaques, that would be forming outside or your extraneuronal, lesions found in patients with Alzheimer's disease. And this would be the neurofibrillary tangles, which is located in the cytoplasmic or within the neuron. So interneuronal will be a neurofibrillary tangles, while your interstitial would be an amyloid neuritic plaques. And of course, there would be loss or what death, cellular death of the neurons, and it would lead into gliosis or the glial cell proliferations. So at the uh, molecular levels, neurons have internal support structure partly made up of microtubules. A protein called tau helps stabilize the microtubules. And in patients with Alzheimer's disease, it's weak, and it breaks. The tau would be fragile. It breaks, causing microtubule to collapse, and the tau proteins would be clumping together, forming now your neurofibrillary tangles. So this is at the biochemistry level. So we have this normal brain, non-amyloidogenic neurons, and during the pathogenesis of the Alzheimer's disease, you can see in here, this would be the amyloid precursor protein. This is a soluble fragment. Now there would be a cleavage, cleavage here, because of this secretase, alpha secretase, and your gamma secretase cleavage. So it's like dual cut, as you can see in here. And what will be happening in here, is that chop sila. You have the alpha beta monomer, okay, alpha beta oligomers. So if that happens, as you can see in here, there can be an aggregation, okay, amyloid fibril, plaques and tangles, okay, and so on down the line. And ultimately, it would lead into the plaques and tangle formation. Okay, so this is the non-amyloidogenic, okay, pathway. This is the amyloidogenic pathway. Okay, and on your um, cellular level, okay, or on the histopathology, okay, staining with a polyclonal antibody against beta alpha 4 peptide would show an amyloid deposition, this browning thing. Okay, these are the plaques in the brain substance. So we have this plaques here, and in the blood vessels, okay, it would be forming a coat-like lesion. Okay, so that would be a Conger red stain. This is the Conger red stain. Okay, and another stain that can be used to um, yeah, to hasten the appreciation of the amyloid plaques will be a silver stain. So this is a silver stain. Okay, take note of the amyloid core and the trophic neurites. Okay, so this is the morphology of the Alzheimer's disease. You have plaques around the blood vessels, okay, and neurofibrillary tangles, okay, found intracellularly. And on gross morphology, okay, the Alzheimer's brain would be more atrophic, okay, the gyri are atrophic, the sulci are widened, as opposed to the counterpart, okay, brain of the same age. So this is the CNS morphology in Alzheimer's disease, atrophic brain. This is the neuritic plaques in here. Okay, your beta amyloid plaques. Okay, and neurofibrillary tangles. So Alzheimer's disease morphology, early and preclinically, there would be starting degeneration in the entorhinal cortex, then proceeds to the hippocampus. Neuronal loss leads into shrinkage. Changes can begin 10 to 20 years before symptoms appears, and even memory loss would be the first telltale signs. So usually it involves, in the mild to moderate, it involves the cerebral cortex. You can have a mild signs, okay, and moderate signs. So okay, so for mild signs, memory loss can be um, the manifestation, confusion, trouble in handling money. So, ayan. So, pwede mabudol-budol. Okay. Uh, kahit sino, bibigyan niya ng pera niya. That's it. Poor judgment, poor mood changes. So, easily flares up. Okay. Parang nagba-bipolar ang dating kanina. Okay siya. Pero dahil nakakalimutan niya yung mga kaganapan earlier. So, really that would be mm, frustrating for the patient and it would be leading into anxiety. For the moderate signs, increased memory loss and confusion, problems in recognizing people. So the patient will not be able to recall the name even of uh, his wife or her husband. Okay, difficulty with language and thought, restlessness, agitation. Okay, wondering. Sorry for that. Repetitive statements, paulit-ulit siyang sinasabi, like, what's my name, and so on. So, for severe Alzheimer's disease, okay, so this is very unfortunate because of the extreme shrinkage of the brain. Patients are completely dependent on others for care. So, pati mag-CR, going to the comfort room, bathroom, he or she will be along the way. Hindi niya alam kung paano pumunta. Okay? There would be weight loss, seizures, skin infection, groaning, moaning, or grunting, loss of bladder and bowel control. And of course, death usually occurs from aspiration pneumonia or other infections. So it's very, very uh, debilitating condition. So Alzheimer's disease and intelligence in early life, okay, okay, higher skills in grammar and density of ideas are associated with protection against Alzheimer's disease in the late life. So the more that you use your brain, the more you read textbook, if you can read everything in the Robbins, the less the chance that you will have an Alzheimer's disease later on. Just kidding, pero well, study shows that uh, read every day, so that the less the chance that you would have later on Alzheimer's disease. Mentally stimulating activity would protect against Alzheimer's disease. So it's a cliche, use it or lose it. Okay. So coffee, okay, would be a protectant against Alzheimer's. So ayan, kaya wala pa tayong Starbucks dito, pero madami namang coffee shops there for those who are in Ilocos. Sa Norte, meron yung Starbucks. So tea also protects, okay, on the other hand, your tea would be protected against Parkinson's disease. Okay? So if you're watching Grey's Anatomy, I think the wife of Dr. Weber had an Alzheimer's disease. So age-related senile degeneration. So no matter what you do, magsishrink at magsishrink kasi na permanent yung ating neuronal cells. So magsishrink yung ating brain. Mamamatay at mamamatay ang early neurons. So, and of course, with aging, there can be an age-related dementia. So all spheres of intellect are affected. There would be a decreasing mass, a low in the 40s, but it would be rapid in the 70s. Progressive neuronal loss leads into a neuronophagia. Okay, so hippocampus and cerebral cortex are affected. Reduction in the size and numbers, okay, of dendritic branches in surviving neurons, cortical atrophy. There can be here a hydrocephalus that can be appreciated. There will be thickening of the leptomeninges near fibrillary tangles, and alpha beta amyloid plaques will also be appreciated. Increasing in number of astrocytes, there can be and atherosclerosis would make it worse. So let's now go into the other CNS degeneration. So we have the Pick's disease, the Parkinson's, and the Huntington's disease. So for the frontotemporal dementia, this is the second common. Okay, this is the group of dementia affecting personality, behavior, and speech. Okay, so patients who had this type of dementia, the frontotemporal, would be younger as to the age, and memory is not affected late in the age. Many sometimes, like your Pick's disease, you have your FTLD tau. Okay, the next would be your FTLD TD43. Okay, the next common, there would be a semantic dementia. Progressive language problems, you have aphasia would be predominating, and later on leading into dementia. So this is your Pick's disease. Okay, usually it's severe. And it's more earlier in onset, 40 to 65 years of age. However, as compared to your Alzheimer's, this is more less common. Okay, and it would lead into a knife blade atrophy of the frontal. So parang nahiwa-hiwa yan. So frontal and temporal lobes are more common, leading into a progressive aphasia and language dysfunction, behavior and personality changes. Okay, however, most of the memories are preserved. Okay, microscopically, as you can see in here, there would be neurons with round intracytoplasmic peaks body. So parang nabundak, parang nabusog. So those are your tau proteins. Okay, so these are your frontal and your temporal. Okay, just an orientation. Of course, this would be The anterior side, this would be the posterior side because this is your cerebellum. Okay, this is the cerebellum, this is the frontal. Okay. So we have this knife blade atrophy is seen in Pick's disease. Here, oh sorry, over here. Then we have the diffuse Lewy body dementia. So 10 to 15% okay, of Parkinson's with dementia. Okay, so this patient will be presenting with impaired memory of recent events, confusion, language problems. Okay, there can be dementia plus visual hallucination. So the problem is you have accumulation of your alpha synuclein in many parts of the cortex, okay, and substantia nigra. Okay, there will be an atrophy of the cortex, okay, like your autosomal disease. So this is alpha synuclein bodies. Then we have the vascular dementia, which is the multi-infarct, second most common after the Alzheimer's disease. This would be different from the senile dementia. So different pathophysiological types. There can be a mild vascular cognitive impairment, injury secondary to your arteriosclerosis. You have a multi-infarct. If also a single large infarct. There can be an hypertensive lacunar lesions, Binswanger disease, which is a subcortical leukoencephalopathy. And, so patients who are boxers are prone to this vascular dementia or traumatic injuries. Or also there can be a mix, an Alzheimer's disease plus the vascular type of dementia. So we have this dementia pugilistica, which is the punch drunk syndrome, common among boxers, a traumatic event. Okay, so chronic traumatic encephalopathy, okay, progressive dementia, presenting with tremors, focal neurologic deficits, also degeneration in septum pellucidum, staining of the corpus callosum, and even in the substantia nigra. Okay, also cerebral neurofibrillar tangles and alpha beta amyloid accumulation. So, kaya milyon-milyon ang usapan kapag boksingero like Manny Pacquiao. So, pag hindi siya nag-ingat, pwedeng ganito siya. Puruhan siya. Now, let's go to Parkinson's disease. This is a loss of pigment, particularly in the substantia nigra. So, what will happen kapag nagkaroon ng loss of this pigment? So there would be a neuronal loss, degeneration, loss of the neuron. It will be replaced by gliosis by microglia. And you know that your microglia is a phagocyte, okay, in the CNS. Loss of neuromelanin, neuronal degeneration. There would be a reactive gliosis, okay, and Lewy bodies can be seen also. Okay? So this is the lesional, and this is the normal. Okay? So, kita nyo, wala na. Okay. Wala na tayong tawag dito, pigment in the substantia nigra. So, patients who have Parkinson's disease, okay, mabagal ang galawan. Okay. So, pag uupo siya, siguro 10 minuto bago siya makaupo. Pag magsusulat siya in writing, there would be tremors. Hindi fine na yung writing niya. So, bagal-bagal. Parang pagong. It's like a turtle. Then the Huntington's disease. Okay, this patient will have dementia, depression, cuneiform movement or jerking dementia. Nag-flare yung kamay niya. Okay, so that's it. That's Huntington's disease. Usually, it's an autosomal dominant in the fifth decade, and it's located on 4P, producing your huntingtin. Okay, this is due to an excess CAG, so CAG tandem repeats. Okay, so therefore there will be an atrophy rather of the caudate and the putamen. Okay, then there will be a compensatory hydrocephalus of the lateral ventricles. Okay, so this is the striatal atrophy. Okay, so the normal brain on the left. and the Huntington brain on the right. Okay, this is striatum, okay, and the striatum of the patients with the Huntington's disease. Okay, so we are done with the primary degeneration. There can be secondary degeneration on the other hand, and also disorders of the myelin. Now for the metabolic CNS disorder, alcoholism induced CNS disorder. So yung mga manginginom can develop a Wernicke syndrome due to the vitamin D1 or thiamine deficiency. This can lead into ataxia or confusion. Also, Korsakoff syndrome, we have the memory impairment. Then there can be also central pontine myelinalysis, cortical atrophy, okay, and even aside from the cortical atrophy, there can be a cerebellar vermis atrophy. So this is an autopsy of a patient with a Wernicke's encephalopathy, recurrent petechial hemorrhages in the hypothalamus, and even the mammillary bodies will have an atrophy. So the Wernicke syndrome will have an altered thermal regulation and consciousness, and even ophthalmoplegia and even nystagmus. Okay, so there is a Korsakoff psychosis wherein loss of recent memory is compensated by confabulation. Ano pangalan mo? Gano'n lang siya. So, di mo ito na yung sasabihin niya. So, for your Korsakoff disease, there would be a central pontine myelinolysis, demyelination of the center of the pons. Okay, here. So, shrunken, brown mammillary body, okay, indicating chronic stage. The cause is unknown but usually seen in chronic alcoholics and associated with rapid overcorrection of the hyponatremia. Alcoholic cerebellar atrophy can also be seen. Okay, there can be a shrunken folia, okay, and widened fissures of the anterior superior vermis of the cerebellum, and another changes which may be found in a chronic alcoholic. So for your vitamin deficiency and neuropathy, your alphabets A, B, C, E. So it's a benign intracranial hypertension can be seen. Okay, what else? Um, for B1, there can be a Wernicke-Korsakoff syndrome. For B2, deficiency, peripheral neuropathy, okay, ataxia and dementia. Also for B6, you have convulsions in infants. B12, a weakness and paresthesia in the lower limbs. Okay, so fasciculus gracilis will be affected. And for vitamin E, vitamin C deficiency, scurvy, poor wound healing. Okay, for vitamin E deficiency, weakness, sensory loss, ataxia, and even nystagmus. So for the neuronal degeneration, okay, we're done with this. We're done with this. Okay, so let's go now to the disorders of the myelin. For the demyelinating disorders, okay, so we have a selective myelin damage, okay, leading to axon damage, defective transmission of impulse. Uh, so as discussed earlier, we have this selective myelin damage or the axon damage, defective transmission of impulse. So patients with demyelinating disorder will have D, means you get rid or defective in the myelination. So loss of the myelin sheath. You know that your myelin sheath is an important um, structure that is found among the axons for faster saltatory conduction. Okay, and there can be inflammation, there can be gliosis, secondary axon damage, okay, in a demyelinating disorder. So there can be an immune type, okay, as seen in multiple sclerosis, vitamin deficiency, so B12 lang, okay, metabolic, like the CPM, central pontine myelinolysis for patients for alcoholics. Also infectious in etiology, your Creutzfeldt, okay, leading into PML, also in immunocompromised patient, genetic, for patients who have leukodystrophy. For MS, multiple sclerosis common, usually 1 in 1,000. Okay, adult females. Okay, there is a genetic predisposition located in HLA-DR2. Okay, earlier in onset if they have this one, so less than 50 years of age. However, it's an autoimmune, so therefore genetic, environmental, okay, and autoimmune, okay, would all eventually be playing factors. Episodes of limb weakness, paresthesia, relapsing and remitting, okay, progressive, and it can lead to death, okay, in a chronic stages. Multiple soft pink plaques here. So multiple pink plaques. Okay, these are demyelination areas. Okay, it's usually, okay, around the ventricles, periventricular. There will also be inflammation, perivascular T lymphocytes and plasma cells can be appreciated, and there will be findings, okay, protein accumulation, oligoclonal IgG bands, okay, if we examine, okay, by electrophoresis of your CSF, and there will be reactive gliosis. So this will be the lesion, okay, for the multisclerotic patient. So uh, we have subtle changes in here. Okay, as pointed by the arrow, those are your sclerosis. Sclerosis, okay, ang namamatay, di ba? When you say sclerosis. Okay, we have a higher magnification here, demyelinated plaques. Okay, and this is a histopathologic section. Okay, so demyelinated areas. Okay, it would show loss of myelin, okay, with many lipid here and macrophages around the blood vessels. So this is the microscopic, okay, and gross findings in patients with multiple sclerosis. Okay, in the MRI studies, okay, kita nyo to, naging atrophic, okay, parang naging kamay ng jellyfish. And we have plaques, okay, that can be appreciated. Sclerotic area is seen in the gross. So we have a gross finding in here, multiple sclerosis in patients with seen in MS patients having the periventricular plaques. Okay, so on your right would be the normal part of the brain, and on the left would be the lesion. So a sharp area of myelin, okay, the white area, and the blue would be the myelin stain. Okay, this one no more myelin. You have a plaque containing fibrillar astrocyte, a T lymphocyte, and macrophages and cells. Normally myelinated, okay, that what makes white matter because of the myelin. Pero kung wala yung myelin, okay, so you have a demyelination, and that can be seen in patients with multiple sclerosis. Now we have also your ALS, amyotrophic lateral sclerosis, okay, also known as the Lou Gehrig's disease. This is the second, the most common type of motor neuron disease, MNDs. So there is a genetic predisposition, okay, mutation in the SOD gene on chromosome 21. There is a progressive neuron loss. Usually patients who are middle-aged, men, okay, sporadically more common, okay, familial to a minor extent, only 10%. Muscle weakness, fasciculations, spasticity, sensation would be normal. Also, degeneration of the lower motor neuron tracts in the lateral portion of the spinal cord, or what we call your lateral sclerosis, and the upper motor neuron, okay, on the Beck's cells in the motor cortex. So there can be subtypes in your Lou Gehrig's disease. Okay, there can be a progressive muscle atrophy. It's a lower motor neuron. If it's upper motor neuron, it would present as a primary lateral sclerosis, and there can be also the progressive bulbar palsy. So we have here a good table for the different CNS degenerative lesions. So we have the Alzheimer's disease, the you have plaques and neurofibrillary tangles, okay, composed of beta amyloids and tau protein. Location, okay, beta amyloid, extracellular, okay, and your neurofibrillary tangles on the intracytoplasmic. For the Pick's disease, it's a neurofibrillary tangle composed of tau protein, but it's only inside intracytoplasmic. For dementia with Lewy bodies, it's a Lewy body lesion, okay, and it's composed of alpha synuclein. It's just inside. For the Parkinson's, it's a Lewy body also, alpha synuclein, and it's in the intracytoplasmic. For the ALS, amyotrophic lateral sclerosis, there will be spheroids, neurofilaments, okay, composed of these subunits of NF, superoxide dismutase, and it's also intracytoplasmic. And multi-system atrophy, glial inclusions, made of tau proteins, and it's also intracytoplasmic. So Alzheimer's is quite unique because it has this extracellular component. So there can be some of the clues in here, okay, for the Purkinje cells, okay, common pathology. Uh, if you have a damage in the Purkinje cells, secondary to more or less alcoholism, carbon monoxide, and ischemia. Mammillary bodies and Purkinje cells usually affected in patients who have vernix encephalopathy. DM of the thalamus, okay, Korsakoff psychosis, hippocampus, Alzheimer's, okay, methanol toxicity, yung mga umiinom ng tuba or yung mga fermented liquors in provinces, alambanog, okay, di ba may uso yan dati, may flavor pa, may color, may blue, may red, may strawberry, and so on. But be careful, sometimes it can be contaminated with the methanol, okay, and it can lead into blindness. Okay, anterior horn cells, it attacks it's the favorite site for the polio and lower ALS also. Globus pallidus, carbon monoxide poisoning. It's a site of lesion. Wilson's and kernicterus as well. Posterior column, B12, syphilis, tabes dorsalis, caudate nucleus, Huntington's chorea, frontotemporal degeneration among Pick's disease, deep brain stem, okay, in a progressive supranuclear palsy. Substantia nigra, okay, pag have a lesion is located and localized in the substantia nigra. Oh, wala ka na ibang iisipin. More or less, it's a Parkinson's disease. The loss of the pigments in the substantia nigra. Upper motor neuron, and of course, in the ALS. So we are done. Okay. So there are minor learning issues. Okay. As well. Uh, Manganese, lead poisoning. Now let's go to uh, quite also interesting that the brain have a tumors. Okay. So what are the general principles in the CNS tumors? 10% of all tumors, okay, is occurring, okay, in the CNS. 10 to 17 per 100,000. The common solid cancer in children, yes, brain tumors. Ang mga primary tumors in pediatrics would be leukemias. The next would be CNS tumors. So the age it has a double peak during 1 to 10 years of age. Tapos 60s and above, nagpipeak na naman siya. And the predilection, adults 70% would be supratentorial, here above the tentorium cerebelli. For the children, it's an infratentorial. Metastatic tumors are most common. Okay, so until proven otherwise, brain tumors will be suspected for metastasis. Okay, Primary tumors are more of glial in origin. Okay, very rare extraneural spread and location. Okay, and not nature determines prognosis. So for adults, supratentorial. Okay, for pediatrics, it's an infratentorial. So these are the common CNS tumors. Okay, so non-glial tumors will be non-glial. Ibig sabihin, ano ba yung mga glial cells natin? Yan, Schwann cell, dendrocytes, astrocyte, the animal cells, and the microglial cells. So those are your glial tumors. Okay? Kung doon sila nag-arise, it's a glial tumors. But we have also the non-glial tumors, like coming from the meninges. Okay, we have the meningioma. Okay, remember our meninges? We have the dura, arachnoid, and the pia mater. So, yung meningioma, para lang siyang nakaupo. It sits, it's an extra. Okay, it's outside. Okay, so it would be arising from the meninges. So therefore, madali lang, it's a resectable kung meningioma. But of course, meningioma, meron tayong what we call atypical meningioma. The atypical meninge is, of course, mas uh, bad ang prognosis as compared to the low grade, okay, or yung typical meningioma na tinatawag namin. Okay? So, aside from the meningioma, meron din tayong mga astrocytoma, oligodendroglioma. Okay? Then we have the, ano pa ba? Pontine glioma. Okay? And we can have also the astrocytoma in the child. Remember kapag babies, infratentorial. Okay? Pag pediatrics, infratentorial. Okay? Pero kapag adults, it's a supratentorial. So there, pag adults. Okay? Then, common sa mga bata, infratentorial, like medulloblastoma. Okay? So, location-wise, pag sinabi mong medulloblastoma, infratentorial yan. Pag yung tumor mo nandito, tapos tapos ang magiging histopathologic report is a medulloblastoma, it's mostly it would be quite unlikely for that because location wise medulloblastoma is infratentorial, and on age medulloblastoma should be among pediatric patients. So pag sinabi din namin na ependymoma, it's usually infratentorial, and here it's located in the fourth ventricle. Okay, and schwannoma, okay, so it's usually from the cranial nerve 7. So therefore, kapag may brain tumors, kailangan namin as a pathologist, we need radiologic studies. Okay, CT scan, MRI, or it would give us already a clue, okay, kung ano yung tumor na pinag-uusapan natin. So here, meningiomas, okay, for adults, gliomas, okay, astrocytoma, and oligodendroglioma. Okay, although, okay, gliomas can also occur, okay, sorry. Gliomas, in particular, this is an adult lesions. For the pediatric lesion, astrocytoma, okay, and medulloblastoma in peds. Okay, so that's the delineation. Okay, supratentorial and infratentorial. So as to the classification, in secondary tumors, ang if there is a brain tumor na sinabi natin kanina, you think first of a metastatic. This is the most common, 50%. Coming from the breast, the lung, the GI, and even from the malignant melanoma. So, primary tumors usually not coming from neurons. Okay, usually it's coming from a glial in origin. That's the most common. Astrocytoma, okay, and glioblastoma. Okay, oligodendroglioma and ependymoma coming from a nerve sheath, schwannoma, and neurofibroma. Meninges, meningioma. Pwede rin magkaroon ng germ cell tumors. Okay, these are your medulloblastoma, neuroblastoma, teratoma. So, hindi lang sa ovary, mayroong teratoma. Pwedeng mangyari din doon sa brain. Neuroma and neuroganglioma. Okay, pwede rin magkaroon ng lymphoma. That's the most common also in pediatrics, CNS lymphoma. So, other tumors of the blood vessels. Okay, so we have the angioma, epithelial type, pituitary, and pineal gland tumors. So clinically, it would present as a slow, progressive, okay, crescendo type. It would be chronically standing, okay, morning headaches. That's the most common. Okay, we had a friend, unfortunately, hinayaan niya lang, lagi lang siyang umiinom. Okay, she would often take arcoxia, eterocoxib, which is a powerful NSAIDs. So, COX-2, okay, selective inhibitors. So, yun, routine niya, everyday, ginawa niyang vitamins, ang eterocoxib, and until the pain is so severe that she can't handle it anymore. So, she decided to have a scan. Unfortunately, the tumor is already big. It's already 10 cm, and it's a glioblastoma multiforme. It's the worst tumor that a brain can have, glioblastoma multiforme. It's a WHO grade 4 already. So local damage can happen, nerve and tract deficits, unilateral paralysis, vision defects, even as anosmia and seizure. Pag masyadong malaki yung brain tumor, it can lead into this types. So magsi-seizure, tonic-clonic seizures. Raise intracranial pressure, so it can lead into headache, vomiting, slow pulse, and even papillary edema. So these are the signs and symptoms of the CNS tumor. Headaches, parang may pa-breakfast ka lagi na headache, morning headaches. Papillary edema, nausea, vomiting, bradycardia, seizures, drowsiness. Even personality changes or memory gaps, changes in speech, limb weakness, depende kung saan na-affect. Balance, stumbling, eye movements, or vision impairment. Okay, the reason for that would be increase in the ICPs, nausea and vomiting if it's in the medulla oblongata, bradycardia if it affects your parasympathetic, seizure leading into irritations, brainstem compression can lead into obtundation, nagtutulog-tulog. Okay, personality or memory, sa tingin nyo, it would be more on the frontal lobe. Changes in speech if it's in the temporal lobe. So limb weakness if it's in the anterior to the central sulcus. Okay, balance, okay, if it's located in the cerebellum. So therefore, you can localize. Okay, even if you don't have, okay, uh, the benefit of the CT scan by history and PE, malolocalize mo na, di ba? Importante yan. Pag-localize ng tumor, okay, lalong-lalo na kung if you are thinking of a brain, okay, or a CNS, there's pwedeng spinal cord, malolocalize mo rin kung anong level yung patent pa or what we call pa affected. So this is a good anatomy of the brain. Okay? So, kung saan ang na-damage, nadali, okay, again, your central sulcus, okay, motor anterior, posterior will be sensory. So, if it's a frontal lobe, personality, emotion. Cannot solve the problem, baka may frontal lesion. Okay, so, manhid ang boyfriend mo, baka ang girlfriend mo, baka may parietal lobe mass or lesion. So hearing, so nandito, okay, and so on. So temporal lobe, speech, occipital lobe, area 44, occipital lobe, vision. Cerebellum, control the balance and coordination. So hindi niya na kayang maglakad ng nakapikit na straight. Oh, so nandun ang lesion sa cerebellum. Natutumba siya. And so on. Nafo-fall siya sa'yo. Okay, so take note of those. So adults, okay, as to the tumor, okay, so majority of the pie will be contributed by glioblastoma for adult patients. Then, sorry, majority would be metastasis for the adults. Then followed by glioblastoma purme. Then we have the meninge, the astrocytoma, and the schwannoma. For children, majority will be an infantorial, of course, and it would be an astrocytoma. Okay, and also, okay, followed by the medulloblastoma. Other lesions, ependymoma, and well, pwedeng lymphoma for that matter. So this is a gross picture of your meningioma. So meningioma is not a glial tumor, okay? Than glial tumor. So it just sits outside the brain. So arachnoid granulation, fibroblast, venous sinuses attached to the dura. Okay? So females are more common to yeah, to have meninge 2:1, and it's being linked to progesterone uh, because of the cyclical changes in the hormonal status of the female, and pregnancy can also play a role. So the common site is on the parasagittals, on the falx, okay, cerebri. It has a slow growth, well differentiated and demarcated. Usually, kapag benign, it should not invade the brain. But if there is a brain invasion, okay, it's already the what we call the atypical meningioma. So this is a gross picture. Okay, or sorry, we have also a reactive scala. Okay, hyperostosis over the tumor or umuumbok. Okay. So this is a gross picture of the meningioma. Note the location in the venous sinuses and the adherent lesions to the dura. So tanggalin, we just remove this, and the patient will be able to survive longer. We had a batch in the residency training, uh, a resident of ophthalmology had a meningioma. So niresect lang yung meningioma niya. And yes, he is already a consultant like me now, an ophtha consultant in St. Louis. So here, okay, this is the meninge. Okay, so it's a resectable tumor. It has a good prognosis. So kung papipiliin ka ng brain tumor, meningioma will be a great one because it's resectable. Okay? Sometimes they are multiple. Okay? So meron tayong multiple meninge. Okay? So this is uh, a clue. This is the pituitary gland. Okay? Um, this is the blood vessel. Then this is the brain tumor, the meninge. So yung meningioma, nakaupo lang siya. Okay, pwede nating ma-lift. Okay, pag ni-lift yung meninges, nandun siya. This is the meningioma. Kaya lang, syempre, itong patient na to, patay. This is an autopsy. Boom. Uy, may extra brain siya. No, that's not an extra brain. It's a tumor. It's a meningioma. Okay? That's the compression. So, dahil ito ay nasa frontal, the frontal area. So, pwedeng may frontal manifestation. Okay? So, pwedeng, ano ba, behavioral changes, so on. Decision making. So, we can have this high-grade meningioma. Okay, so, or the atypical meningioma. So, this is quite rare. Okay, makikita niyo it's quite invasive already into the brain parenchyma. Okay, so, what does the meningioma look like, okay, on the microscopic view? So it's made up of encapsulated spindle cells in whorls. Yan, nagbibilog-bilog siya. And we call it your Samoma bodies, the common type. Okay, ito yung picture niya. So ang Samoma bodies, not only what's the most, if you talk about Samoma bodies, okay, what rings on the bell? The first would be your papillary thyroid carcinoma. But it's not exclusive. Walang exclusive copyright ang papillary thyroid carcinoma sa samoma bodies. Okay, other tumors that can present with with samoma body is meningioma. So we can see here nodules. Okay, this is a photomicrograph lesion. Okay, of your uh, meningioma. Samoma body on a closer view. We have our classification. It's composed of a world nests of cell. A variety of patterns are possible. So, but usually it's composed of a plump pink cells. A small amount of brown granular hemosiderin can be present here. And meningiomas may also have samoma bodies here, what you have seen earlier. So gliomas are neoplasm of glial cells, commonest both in adults and children. Okay, it can have benign to aggressively malignant. So astrocytoma would be one of the example of glioma. There is a low and high grade ependymoma. It's quite rare and it's located specifically in the fourth ventricle. And oligodendroglioma usually are benigns, okay, and seen among also adults. And it's quite rare also. So astrocytoma, okay, um, okay, it's a glioma. Okay, adults, this is the most common, located in the cerebral hemisphere. Okay, low grade, made up of solid and fibrillar glioma. If it's a high grade, it's what we call it already glioblastoma or GBM. Glioblastoma multiforme, variegated. So hemorrhagic and malignant. Children can have cystic low-grade astrocytoma, and we call it that in particular pilocytic astrocytoma. Okay, and kung adults, supratentorial, pag kids, infratentorial, located in the cerebellum. So the mutation is due to the IDH1, IDH2 are the common in low-grade astrocytoma. Okay, uh, this is a low-grade fibrillary astrocytoma. Where is the lesion? It's a subtle change. Okay, here is the lesion. Another there. Okay. Another lesion. That's astrocytoma. Then we can have a glioma of the brain stem. Okay. There'll be a diffuse tumor there. Brain autopsies. Okay. We can have also cystic degeneration of the cerebral hemisphere. Yeah. This is a scan of a patient with a glioma. Where is the lesion? There. A non-enhancing lesion. We have a astrocytoma of the lateral ventricle. There. There are petechial hemorrhages. And we have the astrocytoma of the brainstem in here. Where is it? There. So this is a microscopic view of the astrocytoma becoming hypercellular, eosinophilic. This is the brain. On the left would be the lesion. Sorry, on the left would be the lesional side. On the right would be the normal brain. So adults, okay, this is the dictum, cerebral. We have pointed earlier. Again, if it's a high grade, we call it GBM, glioblastoma multiforme. So what's a GBM? It's a high grade type of astrocytoma. We call it your WHO grade 4, commonest and malignant brain tumor in adults. And kung may GBM yung patient, magpaalam ka na because the mean survival is less than 1 year. Okay? Usually, adults, and therefore it's a supratentorial, cerebral in the patient. There will be a loss of the heterozygosity of chromosome 10, 80% which most GBMs have lost one entire copy of chromosome 10. There are two types, a primary or secondary. Primary or secondary, ito yung galing sa astrocytoma na mutate, eh, it has a better prognosis as opposed to the de novo GBM. Variant will have a giant cell GBM, glioblastoma, and let's look on the microscopy. Meron tayong presence of necrosis, palisading. When you say palisading, naglilinya-linya sila on the periphery. There is hypercellularity, nuclear atypia, vascular proliferation, and lastly, high mitosis. So this is the pathway for the genetic abnormality in the glioma from a low grade, okay, tapos magiging anaplastic, then to the ultimate pang graduation, GBM. Okay, so there is a P53 inactivation, okay, leading into PDGF alpha overexpression, 17P deletion, 21Q deletion, leading into astrocytoma. Then, the astrocytoma, which is a low grade, can have further mutation, RB gene inactivation, 9Q, 16P, and 19Q deletions, leading into an anaplastic astrocytoma. Then, there would be an EGFR amplification. That's the parang ano na yan, pang pinale, leading into a glioblastoma multiforme. So these are the 3 points of or what we call the manifestation from astrocytoma to anaplastic astrocyte to the GBM. And here we can see this is already a high-grade tumor. Kahit na hindi ko pa nabasa or hindi pa yan nababiopsy, pagtingin lang namin sa scan, pangit na ito. So, meron ng edema, may pamamagana ng peritumoral areas. There is a brain invasion, yung capsule niya nag-evade na dito. There is a midline shifting. Ay nako, this is a worst already. So, most likely, kapag na-biopsy, this is already a GBM. Okay? This is an MRI of the GBM patient with enhancement. Okay, nag-enhance and peritumoral. Itong nagda-dark na ito, that's an edema. Bad for this patient. And on gross morphology, okay, madugo, hemorrhagic. Okay, this is an invasive, okay, brain tumor. And most likely, and it's proven, it's a GBM, glioblastoma multiforme. Another patient with a GBM, okay, nakikita nyo itong area ito, yung parang cheese-like area, that's a necrotic area. That's a GBM. So one of the differential is TB of the brain, CNS TB. Okay? Pero until proven otherwise, so kailangan pa rin i-biopsy, is it a TB or a GBM? Okay? So, kasi ang TB ganito rin, magkakaroon ka rin ng necrosis, castration, necrosis. So this is another picture of a patient with a GBM, necrotic brain. It's a multifocal. And another brain tumor with a GBM. Bad for all these patients. And here is the microscopic section, my favorite, of course. So therefore, you can see hemorrhagic area, very cellular. There is a hypercellularity. There is a lining on the periphery. We call it the palisading. There is hemorrhage. Okay? And necrosis. Saan dyan yung necrosis? Itong center mo, pink na lang natira. So this is a necrotic area. So, hypercellularity, necrosis, hemorrhage, and palisading will all point out into a GBM. Of course, you should have a brain specimen. So, yun. So, hypercellularity, palisading, hemorrhage, and necrosis, all in one. Now, a higher view, a closer view. Okay. So necrosis, we have hemorrhage, hypercellularity, and we have this palisading. Naglilinya-linya. Pila-pila. Walang singit. Walang singit. Again. So, so this is a letter A. Astrocytoma, a low grade. This one is, so this is a gross specimen of a low grade brain tumor, a high grade brain tumor. And this is of course the histologic section of letter B or G. So, astrocytoma, okay. So we're done with the adults, DBM. Now let's go to the children. So the most common is your pilocytic astrocytoma, and it's usually intratemporal cerebellum. So ano bang mukha niya? Children, slow growth, usually it's located in the cerebellum. Di ba? Cerebellum ito. Ito yung arbor vitae. Okay? Yung folia ng ating cerebellum. So meron kang cystic with mural nodule. So, cystic lesion with a mural nodule. Microscopically, it's composed of elongated hair-like cells or pilocytic cells. Oh. So this was dated 1964. So hindi pa rin naman nagbago. So there you go. A brain tumor, cystic lesion. Okay. Still, yung patient is a child. Of course, autopsy na itong specimen na ito. Matanggal ba naman ang cerebellum? Siyempre patay. Okay, so this is a scan of a patient. It's an infratentorial in location. Okay, you have a cystic lesion on the posterior side. So it's the cerebellum. So most likely, kahit yung neurosurgeon, okay, so Dr. Viado, okay, would most likely. So again, this is a scan of the pilocytic astrocytoma. So remember, it's a pediatric tumor, and it would be an infratentorial. So you have a solid, okay, solid lesion with a brightly contrasting, enhancing the mural lesion, mural component, and associated cystic lesion. So it's in the cerebellum. Okay, so even though there's no biopsy yet, but with the correlation of the age of the patient and the location of the tumor, okay, that would definitely be a pilocytic astrocytoma. So on microscopic view, this is the picture, okay, of the pilocytic astrocytoma. There can be also a palisading pilocytic astrocyte, and on higher magnification of the intervening structures or its trauma, we can appreciate that there would be a plenty of rosental fibers between cells. So let's see. Let's have take a look. Okay, the tangles that you can see in here, as if they are having a tail. Okay, this is what we call your rosental fibers, and it would only be epithelmonic of the pilocytic astrocytoma. Next tumor for pediatric patients would be your medulloblastoma. So again, a common tumor for children, and it's also in the cerebellum. Remember, most of the tumors of the pediatric, okay, for CNS would be intratentorial. So it's the cerebellum that would be affected. Okay, however, your medulloblastoma is a primitive neuroectodermal tumor. Okay, and we can appreciate blast cells, okay, with round, scanty cytoplasm, and it's also on the fourth ventricle, but commonly it would result into a obstruction. Therefore, there would be hydrocephalus. So the CSF, okay, would be a channel for them. Okay, they would seed off. Okay, they can also cause meningeal infiltration, okay, which is also common. And what's pathognomonic for this type of tumor is they form rosettes, okay, parang flower, and neuronal or glial differentiation is rarely seen. So this is a medulloblastoma. It's a primitive neuroectodermal tumor found among children, and usually it's located in the vermis, okay, of the cerebellum. Okay? So we have here a multifocal. So this is the origin of the tumor going into the site. So another, okay, picture of the medulloblastoma. Again, where is the lesion? It should be in the cerebellum. Then this would be the cerebellum, and this enhancing white ill-defined mass, okay, that would be the site of the tumor, and this is the scan for this patient. So on microscopic examination, we can appreciate that this tumor is quite hypercellular, and it's made up of a round, okay, to ovoid blue cell tumors, okay, and it's the nucleus is quite large. The cytoplasm is very small. It's quite neat. You cannot appreciate it. And they would be forming rosettes, or what we call a flower-like structure, the rosental rosettes. Okay, so the rosettes pathognomonic for the medulloblastoma. Now, another tumor for pediatrics would be lymphoma. This is a rare, okay, 1%, but most common CNS neoplasm in immune-compromised patients, transplant recipients, and patients who had or is having an HIV or AIDS. Usually, it's secondary also by infection due to your Epstein-Barr virus. Okay, usually, it would be the large B cell lymphoma, not the T cell, and they would have a poor response to chemotherapy. So the tumor, okay, if it's diffusely infiltrating the brain, and it would be composed of round blue cell tumors. However, there is no rosette formation because remember, your um, medulloblastoma, which is also composed of blue cell tumors, okay, small round blue cell tumors, okay, would be forming rosettes. But here they don't. And of course, the location. Okay, for the medulloblastoma, it would be on the cerebellum, while for lymphoma, it would be on the cortical, diffusely infiltrating. Okay, so therefore, for the CNS tumors, okay, for adults, okay, usually it's metastatic, involving the lung, the skin, and the breast. And in adults, again, it would be a supratentorial, okay, primarily astrocytoma, glioblastoma, and meninge. For children, that's the second most common, okay, well, after your leukemia and lymphoma, okay, and it's an infratentorial in location, okay, majority of which will be the astrocytoma, the cystic cerebellar type, okay, and or the pilocytic astrocytoma in particular. We have the medulloblastoma. Okay, also they would have commonly children would have hydrocephalus, and meningeal spread is common as well. Again, supratentorial, infratentorial demarcation. Then another lesions would be your AV malformation. This is an AV malformation, arteriovenous malformation. Okay, so now we have also pathology of increased pressures, intracranial pressure. So increased intracranial pressures, we have the pathogenesis and clinical manifestation are as follows. They would have ischemia, hematoma, infections, or tumor. And the pressure for the CSF would be more than 14 millimeters mercury, leading into cerebral hypoxia, ischemia, and edema. For the cerebral edema, they can lead into a vasogenic type, okay, secondary to inflammation. Okay, tumors are cytotoxic, hypoxic, or even toxins. Clinically, okay, they would be presenting with headache, impaired consciousness, vomiting, bradycardia, arterial hypertension, and of course papilloedema. There will be false localizing signs like ipsilateral pupillary dilatation and hemiparesis, sixth nerve lesion unilateral or bilateral, and even they would have a positive Babinski sign. So cerebral, okay, this would be the complication of increasing the cranial pressure. Number one, there would be a cerebral herniation. Right? So herniation is an abnormal protrusion of the structure, okay, to the non-normal area. So example, okay, there would be a supratentorial herniation. Okay, there would be three types. We have the subfalcine herniation, central transtentorial herniation, and the uncal herniation. For the subfalcine, this is the most common, wherein the cingulate gyrus of the frontal lobe will be herniating out. The central transtentorial herniation would be the displacement of the basal nuclear and cerebral hemisphere downwards. And the uncal herniation, this is the medial edge of the uncus and the hippocampus. And of course, we have also the cerebellar herniation. For the cerebellar herniation, this is an infratentorial or below, wherein the tonsils of the cerebellum is pushed through the foramen magnum, so the biggest hole, okay, of the skull going that would lead into the exit of the spinal cord. However, with increasing the cranial pressure, um, the brainstem and the cerebellum can be pushed downwards, leading into the cerebellar herniation. It would compress the medulla, leading into bradycardia and even rest. So this is a diagrammatic representation of the different herniation. You have the subfalcine herniation. Okay, so it's the most common, leading into a headache, contralateral leg weakness. Okay, and then we have that transtentorial. Okay, so usually the patients would have uh, cranial nerve 3 or oculomotor paresis, which is manifesting as a ipsilateral dilated pupil, abnormal EOMs, and contralateral hemiparesis. And this one, your tonsillar, okay, uh, herniation leading into an obtundation. Now, your subfalcine herniation in the brain, trauma, okay, this can happen, and especially it would result into the contusion of the inferior temporal lobe. Okay, this is the inferior temporal lobe. Okay, it can result into a diffuse edema due to the compressed and flattened gyri on the right. This has resulted in a subfalcine herniation of the cingulate gyrus here, with secondary hemorrhagic infarction, okay, above this one. Okay, then a midline shift. So this is the midline. However, it went to this area. There's a midline shift from the right to left is also present, as is uncal herniation. So this is a gross, okay, picture of an acute brain swelling, okay, leading into an uncal herniation. Okay, so there is a swelling in here, okay, of the left cerebral hemisphere, with shift with herniation of the uncus of the hippocampus throughout the tentorium, leading into the groove seen, okay, with this arrow. Okay, this is another type of herniation, your central pontine, okay, herniation, okay, with a direct hemorrhage. Okay, this is a cerebellar herniation. Okay, so we have this cone-shaped cerebellar tonsils here, okay, around the medulla in the cerebellum specimen, resulting in decompression and direct hemorrhages in the pons. So let's see the microscope or the cat section here. Okay, there's a direct hemorrhages here. So clinically, they would be presenting, okay, with this manifestation. So transtentorial, okay, it can lead into an ipsilateral third cranial nerve compression, so therefore fixate the related pupil. Ipsilateral sixth nerve cranial nerve 6 cranial nerve compression. So you can have diplopia, convergent squint. Posterior cerebral artery compression, okay, cerebral peduncle compression, and even brainstem compression and hemorrhage. Okay, sometimes they can go out into the foramen magnum, okay, leading into brainstem compression and hemorrhage. So this would be manifesting with decerebrate posture, okay, so with a cardiorespiratory failure death. Then acute obstruction of the CSF pathway, of course, that can lead into a decerebrate posture and cardiorespiratory failure. Okay, so this is decerebrate. Okay, it's the opposite of the decorticate. For the decorticate, the elbows, wrists, and fingers are flexed, legs extended, and rotated inwards. So, well, pupils will dilate because remember your sympathetic and parasympathetic. So, non-opposement of the sympathetic can lead into your pupillary dilatation. The point and shoot. So we have here a male patient, okay, having a scan, an MRI scan with a T1 and T2 weighted MRI. And of course, this would be the lesion of interest. Uh, the manifestation, since that's a frontal, so pwedeng tapos, so frontal area, more on the motor, okay, affected. That would be, of course, contralateral weakness, okay, of the affected body. Sometimes we can have also, remember, until proven otherwise, we would think of metastasis as well. Okay, so remember this, your lung, breast, skin, kidney, and GIT. Okay, but usually we don't see prostate, okay, carcinoma going into the brain. Okay, and we can appreciate that you will have a well demarcated, usually multiple with surrounding rim of inflammation. This one. Now, sometimes there would be carcinomatosis wherein there would be a meningeal CSF spread of the malignant cells. Okay, so there are your metastatic tumors. So this one is really a clear cut of a metastatic tumors, particularly malignant melanoma. This is a malignant, rather melanin-containing carcinoma cells with multifocal. Most likely, if it's a multifocal lesion, then we think of a metastatic lesion. If it's a primary brain tumor, usually mag-isa lang niya or only one. There would be a surrounding edema. Okay, here. Surrounding edema here. Okay, on scan, it would look like this. Now let's go to the other CNS tumors. So first in the list would be your neurofibroma. Okay. So we have an epi and endoneural fibroblast derived. It form whorls or fibroblasts with nerves. They form a well differentiated tumors. It's a benign and it's usually encapsulated. Now for schwannoma, this is coming from the Schwann cells. They form an elongated whorls, okay, with nuclear palisading. So it's the mimicker of, di ba may palisading din si glioblastoma multiforme. So this is your schwannoma, okay, versus that of the neurofibroma. Okay, for the schwannoma, okay, we have this perineural sheath, okay, that envelopes it. Okay, here, the endoneuron and the nerve fibers. Okay, so remember your Schwann cell is the one that would be producing your myelin sheath, okay, in the peripheral, in the PNS. Okay, so it would be growing in an uncontrolled manner. So that would be your schwannoma. Okay, as opposed to the neurofibroma, okay, you have proliferating cells of neurofibroma will be more abundant here, okay, within the nerve. Okay, there will be a perineural sheath, the nerve fibers, and the neuron. Sorry, medyo malabo ito. It's a scan of the patients who have a schwannoma of the 8th cranial nerve. Where is the lesion? Guess where? Of course, it's here, the one that is enhancing lesion here. Okay. On the autopsy, okay, this is a bilateral 8th cranial nerve schwannoma. That's the lesion. Okay, and there, two of them. This is the Schwann cells, schwannoma, arising from Schwann cell, schwannoma. So it's made up of a spindle cell tumor, eosinophilic, wavy nuclei, schwannoma. Now we have another lesion in here with a cafe au lait spots. Okay, that would be okay, epiphagmonic for neurofibromatosis. Sometimes it would be multiple. Okay, ang dami-dami nila. So the neurofibromatosis. This is a cafe au lait spots. Sometimes it would be like this. Okay, wala lang tinirang space. Okay, it's a neurofibromatosis. Good luck, you know. So sometimes we have this patient, okay, coming into the clinic, a 26-year-old female with headache, vomiting, with epileptic attack, weakness of legs, non-drowsy. 2 weeks before admission, she gave her second birth. Okay, CT and MRI revealed a huge parasagittal mass, enhanced by contrast, with a compressed corpus callosum and ventricles. So it's like Dr. Shepard from the Grey's Anatomy. Okay, so it's a neuro case. There is the lesion. Okay, and well, uh, neurology is quite interesting. Okay, so seventh nerve palsy. Okay, it can be due to these are some of the differentials: acoustic neuroma, epidermoid cyst, megaloblastoma, and even meningioma. And affected cranial nerves can be if it's a mastication that is being affected, then it would be the fifth cranial nerve. If the facial muscles are paralyzed, it can be the seventh cranial nerve. If hearing, then it can be an auditory. And of course, your signs of meningitis, your Brudzinski, okay, and there uh, would be um, irritation of the meninges with flexion of the leg and neck. Brudzinski Brudzinski sign. Okay. Look at
Jelly.
Oh, dance kay mama. Wala na. Sira, sira.
Sira. Hala na, di ba kita sira yung
Kaya
tela eh.
punta kay mama.
Mukay mama kasi matutulog si Singay. Patulungin kita. Dito baba na. Dito na.
Oo, lagi.
Hindi ka na kita na.
Ah, sorry. Sorry for that. Okay, let's proceed to the cerebrovascular um, disease or strokes. So when you hear the word stroke, okay, it would mean an acute neurological deficit, okay, and usually secondary to your cerebrovascular accident or CVA, and it's secondary to a low oxygen, okay, or a low blood supply, okay. So there would be varying severity, location, and type. It can be transient, okay, evolving, and completed. There can be a global, focal, okay. It can be, well, arterial or venous in origin, or ischemic versus that of hemorrhagic. So your stroke is the third most common cause of death, okay, and the second most common cause of neurologic disability after your Alzheimer's disease. Its incidence has decreased in recent decades, but the decrease appears now to have leveled off, and it remains the leading cause of institutionalization for loss of independence. So, sorry. The brain blood supply features are as follows. It requires a high oxygen requirement. Okay, the brain is only 2% of the body weight, okay, but it needs a 15% of the cardiac output. It must have a 20% of the total body oxygen, continuous oxygen requirement, okay, with no change in blood pressure. Okay, a few minutes of ischemia can lead already to irreversible injury. Okay, I think 5 minutes. So neurons, okay, predominantly are aerobic. They cannot survive without oxygen. They are not anaerobic. So sensitive areas are as follows for adults: the hippocampus, the third, fifth, and sixth layer of the cortex, the Purkinje cells, okay, in the cerebellum, and the border zone or the watershed areas. The brainstem nuclei in infants uh, would be important among pediatrics. So again, it depends on the affected area. The line for demarcation will be the central sulci. Everything that is in front of that would be the motor domain. Everything posterior to that would be your sensory cortex. So for the motor cortex, okay, here, okay, right after the central sulcus, anterior to that would be the primary motor cortex, area 321. Okay, then as I've talked about this earlier, so just a review for that. So this is the Brodmann's cortical map. Okay, so this would be your central sulcus. So everything in front of that would be the motor. So yeah, area 4, area 6. So even numbers 4, 6, 8. Okay, would be the motor. The sensory would be your 312. So let me correct myself for that. So aside from that, okay, mm, notable areas, area 17, vision, okay, primary vision, 41, 42, okay. This 44, 45 would be the Broca's area. Area 22 would be the vernix area. Okay. So, so for the stroke types, okay, we have your TIA, transient ischemic attack. Okay, that resolves less than 24 hours. So may TIA, so yung na-admit na patient, yung ditang inaarte, okay, transient ischemic attack. Okay. Then we have also your evolving stroke. Okay, this would increase if more than 24 hours. Okay, hindi na thrombolized. Okay, it is more or less recurrent multiple stroke or other secondary factors. We can have also the completed stroke, wherein no changes. Okay, usually it's an embolic in origin. For the pathological side, it can be a focal, okay, limited area, or global. Okay, it can be a ischemic versus that of the hemorrhagic. For ischemic, okay, it can be may barang, okay, may bara na napunta, may na throw up na thrombus, uh, so mayroong emboli na napunta doon sa depende, kunyari anterior communicating artery or so on, depende kung saan siya nagbara, or may sumabog, okay, that would be your hemorrhagic. Okay, and venous infarcts, okay, usually for young patients and secondary to infection. Okay. So for infarction, the incidence is we have infarction type and hemorrhagic type. For the infarct, ito yung may bumara. So mayroong thrombus, okay, can be a thrombotic, okay, secondary to atherosclerosis. So like example, large vessel are commonly affected, 30% of which in the carotid and the MCA, middle cerebral artery. For small vessels, usually 20%, okay, it's a lacunar type of infarct. Sometimes, emboli naman, okay, nakawala, okay, coming from a heart or atherosclerosis. So, mas delikado yung embolic because usually it's rapid and it's more extensive and it happens in young patient. Venous, which is thromboembolic in origin, is quite rare. Okay, so on the other hand, the hemorrhagic type of um, lesions, okay, this is of minor, okay, 20% incidence and mortality. However, mas malala kapag hemorrhagic stroke. Okay, kasi sumabog yung ugat, para siyang gripong nakabukas, hanggat hindi nakiklip, hanggat hindi yun na-stop, magbi-bleed inside. Okay, and of course, it would be occupying, okay, a space that would be uh, causing increased intracranial pressure. So the most common causes for hemorrhagic would be berry aneurysm, microaneurysm, atheroba. Okay, it can be an intracerebral or subarachnoid bleeds. So these are the stroke location and incidence. Okay, cerebral infarct. Okay, the most common. It's slow, sudden, involving signs and symptoms. Okay, with 30. However, the mortality rate is quite low. Common siya, pero mabuti na lang hindi masyadong mataas yung mortality for that. Okay, so usually cerebral hypoperfusion, embolism, and thrombosis. Intracerebral hemorrhage. Okay, this is 10% with the sudden onset of stroke with raised intracranial pressure, and the mortality is quite high. This is secondary to rupture of microaneurysm or arterial. And the subarachnoid hemorrhage, this patient will have sudden headache with meningism, okay, and uh, the mortality is also mid with rupture of the saccular aneurysm on the circle of Willis. So these are the hypertensive intracerebral hemorrhagic sites. So ang pinaka-common is putamen. Okay? 55%. Cerebral white matter. Okay, almost the same. So pag may bleed, usually high blood, yun. Putamen. Bleeding tayo. Etiology, complication of several disorder. Atherosclerosis is the most common. And again, it's being linked to hypertension, smoking, diabetes, heart disease, okay, kung merong atrial fibrillations. Other causes would be trauma, fat embolism, tumor, infection, and Caisson's disease. Yung mga nagda-dive, scuba diving. So the risk factors for the non-modifiable risk would be age, male, race, and heredity. For the modifiable would be hypertension, diabetes, smoking, hyperlipidemia, excess alcohol, heart disease, okay, atrial fibrillation, okay, oral contraceptives, okay, that would be a risk factor, okay, and hypercoagulability. So as to the clinical categories, we have global and focal ischemia. For the global ischemia, we have hypoxic encephalopathy, hypotension, hypoxemia, and anemia. For the focal ischemia, obstruction to blood supply to focal area, thrombosis, embolism, or hemorrhage. So let's go to the global ischemia. Okay, usually impaired blood supply, secondary to lung and heart disorder. Okay, impaired O2 carrying capacity, like anemia, impaired oxygen utilization, as in cyanide poisoning. So this patient will have third, fifth, and sixth layer of the cortex death or necrosis with CA1 sector of the hippocampus and in the Purkinje cells and in the cerebellum. So laminar necrosis, hippocampus and Purkinje cells are quite affected. Okay, border zone infarcts or the watershed, okay, are being affected with sickle-shaped band of necrosis in the cortex. Clinical features would involve mild transient confusion state to severe irreversible brain death. Okay, in fact, they would have flat EEG and vegetative state uh, or even coma. So this is the different morphology of the global ischemia. Usually, the watershed zone. Okay, yan. So it can be an acute, usually due to anterior communicating and middle communicating. Okay. So laminar necrosis for short penetrating arteries. Some sector of the hippocampus can be, and the Purkinje cells of the cerebellum. Okay, this is the watershed boundary. Ito yung lagi yung nawawala ng blood supply, the watershed boundary. It's between the anterior communicating and the middle MCA. Laminar necrosis and global ischemia here. Okay. Then we have the local infarct, cell death, 6 minutes, central infarct area or the umbra, surrounded by the penumbra, okay, of the ischemic tissues that may recover. So what happens during the infarct? So um, reduced blood flow leads into hypoxia and anoxia. Altered metabolism, the sodium-potassium blocks is being impaired. Then the glutamate receptor act, leading into a calcium influx. So ischemic injury, there would be red neuron, okay, changes, vacuolation, cell death karyorexis, okay, R's, okay, for that. Okay, then on sorry. Then on one day, there would be inflamm and edema up to the third day. Okay, as it progressed, there would be macrophages on the fifth day, liquefaction, necrosis by seventh day. Okay, and there would be on 1 month glial proliferation. So these are the infarct stages. So kapag less than 24 hours, wala pa kaming makikita pag nagpa-autopsy kayo. So no changes, no gross or microscopic changes. On the cellular level, there would be sodium and potassium loss and calcium influx. Okay, less than 1 week, that would be the acute stage. There would be edema, loss of gray and white matter border. There would be inflammation, okay, red neurons, necrosis, and neutrophils. On the intermediate stage, that would be 1 to 4 weeks, there would be clear demarcation, soft friable tissue or cyst formation. Macrophages and even liquefactive necrosis can be appreciated already. On the late stage, okay, So, kunyari, na-stroke yung patient, tapos more than 1 month, tapos namatay, tapos nagpa-autopsy, there would be removal of tissue by macrophages. Wala nang necrotic area, but it would be fluid-filled cyst lesions with dark gray margins or gliosis. Okay, or the proliferation of glia at the periphery. So it's like these are some of the pictures of the cerebral edema, okay, that would be evident during some infarcts. Okay, there would be narrowing of the sulci. Okay, so halos wala ng space. Okay, flattening of the gyri. Okay, parang nagiging manas yung utak. Okay, so there would be congestion. Okay, flattening of the gyri. Okay, flattening the gyri and narrowing of the sulci. Edema, okay, can also be appreciated, okay, wherein there would be uh, loss of demarcation, so edematous brain. Okay, yan wala na halos yung space. And if we would like to date, okay, the cerebral infarct in here, that's around 2 weeks. Ayan, so meron kang liquefaction necrosis that would be evident. Okay. This one, medyo parang nag-heal na yung infarct. Okay, this is around 1 to 4 weeks. This is a late. Okay. Nagkakaroon na ng scarring. Okay, cystic formation and hemosiderin. So this is the normal cerebral cortex, the white matter and the gray matter. This is the sulci, the S. So white matter here, gray matter, and the sulci. But on the higher magnification, so ano ba yung mga nakikita natin? So itong yellow, okay, arrows, these are your oligodendrocytes. So remember, oligodendrocytes are the one that forms myelin sheath in the CNS. The orange one are your, okay, astrocytes. So ano bang trabaho ng astrocytes? Okay, they are the one that would be responsible for forming a tight junctions, okay, between the neurons and the blood vessels, okay, or the blood-brain barrier na tinatawag natin. Okay, and the blue ones, these are the neurons proper. Okay, so on a higher, okay, higher normal cerebral cortex, okay, and the white matter. So yung white matters are nothing but your glial cells. But if you have a cerebral edema, okay, the left side would be the normal white matter. Okay, itong nasa kanan, okay, this is the edematous cerebral edema, or cerebrum rather. So, ang daming space, edematous kasi. Okay, what else do we have to see in here? Sorry. For this is an axonal injury. Okay. Okay, we have a hypoxic ischemic injury in the cerebral cortex, leading into a shrunken, okay, cells, or what we call the red neurons here. Then we can have a spheroidal, axonal spheroids at the point of axonal disruption. Okay. Then swollen cell bodies, okay, and peripheral dispersion of the Nissl substances or chromatolysis. This is acute infarction, okay, back-to-back comparison of your normal on the right and edematous brain on the left. Okay, higher magnification. Okay, so we have here your normal brain. Okay, here on the left, this one would be the edematous portion. Yung mga malalaking ito, Okay, those are your macrophages. Infarction and microscopy, 3 days. Okay. Parami ng parami ang ating mga inflammatory cells. Okay. Neutrophils, eosinophils, lymphocytes, macrophages. Okay. One day, wala ka pang ma-appreciate. Remember? Okay. You don't see anything on the first day, 24 hours. On the third day, here, medyo dumadami na ating mga neutrophils. Then, on the seventh day, or 1 week, there are a lot of inflammatory cells. More than 3 weeks, okay, well, nagkakaroon ka na dito ng gliosis. On the fourth week, okay, cystic formation. Nalinis na kasi ng mga macrophage yung area na mayroong necrotic areas. So these are the specific focal areas: anterior communicating, okay, MCA, middle cerebral or anterior cerebral artery, rather, middle cerebral artery and the posterior cerebral artery. Okay. The MCA will have a superior, inferior, and deep branches. So, go back to the anatomy. So, depende, kunyari ito, yung nadali, the anterior cerebral arteries. Remember yung homunculus, yung mukha, yung face, okay? Tapos, yung kamay at yung paa. So, yun yung magiging affected. Yun yung mawawalan. Contralateral, yun yung mawawalan ng supply. Yun yung mawawalan ng innervation, rather. So, depende kung saan ang nadali. Kung anterior cerebral, middle cerebral. So, you can localize, okay, the affected part. So, for instance, in your MCA, paralysis of the contralateral face. Ayan. So, MCA. Okay. So, dito, on your MCA, contralateral face, arms, and leg. Sensory impairment over the contralateral face, arms, and leg. Homonymous hemi and chondrantanopia. Paralysis of the gaze to the opposite side, aphasia. Okay. And what else? If it's the penetrating, okay, contralateral hemiplegia or paresis, or even slurring of speech. Okay. So MCA stroke. Okay. We have thrombosis of striae, artery with infarction of the internal capsule. So usually yan mga nagiging delikado yan. Zone of cortical infarction with occlusion of the trifurcation. Okay. The reason for that is usually a thrombus, okay, that was dislodged in the carotid artery, okay, going up. So pag yan, depende kung saang site ang naging affected. So the more it is proximal to the heart, mas marami siyang magiging maapektuhan. Okay, so this is a middle cerebral artery. Okay, these are your major arteries, your MCA, so contralateral face and body arm paralysis plus sensory impairment. We have your homonymous hemi or quadrantanopia, gaze paralysis to the opposite side, aphasia, praxia, agnosia, and even dysarthria. Okay, so ito yung mga kailangan, okay, matanggal, matrombolyze kung yan ay embolic stroke or that leads into ischemic stroke. Okay. If it's the ACA, okay, anterior cerebral, paralysis of the contralateral foot and legs, kasi ito yung nakabitin dito. Okay. Foot and leg, dito yung face kasi. So pag middle cerebral, kamay, mukha. Pag anterior cerebral, yung nakabitin na paa. Okay, so foot and leg, sensory loss over toes and foot and leg, gait and stance, abulia, okay, mabagal gumalaw, flat affect, okay, so slowness, distractibility, cognitive impairment such as preservation and amnesia, and even urinary incontinence. For the PCA, it can lead into a peripheral or central. For peripheral, the patient can suffer from homonymous hemianopsia, memory deficits, preservation, okay, or repeat response, perseveration rather, okay, several visual deficits like cortical blindness, lack of depth, perception, and even hallucination. For central, okay, the thalamus, so it's a relay center for pain, so contralateral sensory loss or spontaneous pain. Okay, mild hemiparesis. Okay, cerebral peduncle, so cranial nerve 3 palsy with contralateral hemiplegia. Brainstem, so pwede rin maapektuhan okay, kapag PCA. Okay, so it can lead into cranial nerve palsies, nystagmus, and even pupillary abnormality. So this is an example of a patient with an arterial embolic stroke. So that area is the sudden pinpoint hemorrhage over a triangular area. Okay, this is a cerebral infarct. Okay, here, uh, 3 weeks old. Okay, and ito mas matagal na ito, siguro 1 month and over. So yung mga patient na na-stroke, tapos 'di ba mayroon kang um, what we call it, mga residual. So, naka-decorticate na sila. Hindi na naka-flex na sila, tapos hindi na makapaglakad, or it's because ganito yung nangyari sa brain nila pag in-autopsy. Okay? Namatay. Okay? Nagkaroon ka ng infarct. And you know that, more or less, this would be medyo wide ito. Mayroon kang anterior cerebral artery and middle cerebral. Okay, artery ang nadali. Okay, kaya ang massive, ang extensive. So ito ay right side ng cerebrum, so the manifestation will be contralateral. Yung opposite na paa, kamay, more or less pati yung facial, may facial manifestation ito kasi middle ano to middle cerebral artery ang na-affect. Okay? So we have your hypertensive cardiovascular disease. Okay, so intracerebral and subarachnoid hemorrhage will be one of its manifestation leading into microaneurysm hemorrhages, basal ganglia, even the putamen, 60% thalamus and ventricles. Also, for hypertensive, berry-aneurysm hemorrhages is common, leading into subarachnoid hemorrhages. Chronic hypertension can lead into dementia, slit hemorrhages, okay, lacunar infarcts, and even encephalopathy. Okay, so headache, confusions, vomiting, and raised ICP. So we have here hypertension stroke. Okay, ayan. Okay, 200 over 120, okay lang yan, Dok, kasi wala naman akong nararamdaman. So pwedeng ito yung mangyari later on, hypertension stroke. This is a large hemorrhage in this adult brain arising in the basal ganglia region of a patient with hypertension. So kahit na sino pang neurosurgeon, kahit na si Dr. Viador, pag ganito nakalaki, hindi niya yan gagalawin. Kasi more or less, they have this cut-off in your GCS. I'm not so sure na kung ilan ang cut-off nila bago nila i-operahan. Siyempre pag yan ay GCS 3, no na yan nagagawin. Useless. Magti-table death lang yung patient. Okay, this is another. Okay, hemorrhagic stroke. Okay, more or less in the middle cerebral artery. Okay, this is a ruptured berry aneurysm. Okay, yan. Okay. Pag yan pumutok, New Year, hindi. Lamay. Yeah, so this is your ruptured berry aneurysm. Ito nag-rupture na. Ito pa-rupture pa lang. So hindi yan taong ano parang ano, 'di ba? Parang taong naglalakad. Okay, this is a berry aneurysm na nag-rupture leading into a subarachnoid hemorrhage. Okay. So this is a subarachnoid hemorrhage. This is a CPM, or rather CP hemorrhage, central pontine hemorrhage leading into herniation. We can have also this fusiform atherosclerotic aneurysm. So here is your berry aneurysm. Ayan, berry aneurysm. So this is the basilar artery, just to reorient you. This is the posterior communicating artery, middle cerebral artery, and the anterior cerebral artery. Ito yung anterior communicating branch. Okay. And ito yung mga berry. Okay. So saan common magkaroon ng berry? So as you can see in here, so common sila dito, 40% sa ACA, anterior communicating artery. Next, okay, between the internal carotid artery, after the internal carotid artery, 20 dito pa pala. 34% in the middle cerebral artery, 20% just okay the internal carotid artery joining. Okay. And the least will be here in the posterior cerebral artery. This is your intracerebral hemorrhage. Yan. So, sigurado patay ang pasyente pag nangyari yan. This is a massive intracerebral hemorrhage. Okay, may pumutok na ugat. Okay, pag ganyan, pumutok, dapat magawa agad ang CT scan or else, patay. Patay ang pasyente. Parang si Dr. Shepard. This is your lacunar infarct. Okay. So for a left dominant, hemisphere stroke, what will happen? Aphasia, right hemipharesis. It's a contralateral. Pag dito ang nadali, it would be the opposite. Ang manifestation. So remember, may decussation ka. Go back to the anatomy. Right visual field defect, poor right conjugate gaze, dysarthria, difficulty reading, writing, or calculating. So that would be a recent cerebral infarct in the left middle cerebral distribution. But if it's on the opposite, the right part, non-dominant hemisphere stroke, the manifestation would be more a defect of the left visual field, extinction of the left side stimuli, left hemiparesis, left-sided sensory loss, left visual field defect, poor left conjugate gaze, dysarthria, and spatial disorientation. Hindi niya alam ang right sa left. For the CNS AV mal, ito yung mga AV malformation. There are many types. So cavernous angioma, telangiectasia, venous angioma. It can cause seizure, disorder, and hemorrhage. Most common is a congenital vascular mal. Typically located in the outer cerebral cortex, underlying white matter. So this is your AV malformation. So it's not a tumor. Tignan nyo, maitim. So ibig sabihin, hindi siya mass. It's an AV mal. It's the blood vessel defect. arteriovenous malformation. Mali yung uh, mali ang kanilang pagtatagpo. Okay, so that's it for your uh, what you call your CNS pathology. So just to re-emphasize, these are the changes during cerebral infarct. These are the red neurons, the neutrophilic infiltration, okay, mga 1 to 3 days. And more than that, okay, macrophage and early gliosis, uh, loss of myelination. Uh, this is infiltration of some of the, this is the low power of this. And later on, okay, there would be cystic degeneration. So that's it for your neuropathology. Thank you, everyone. So I expect that you would have laboratory activities that would be uploaded, okay, in your Google class. Thank you, everyone. Bye.